Hello, welcome to Senior Speak New Hampshire. My name is Dan Wise. I'm an AARP volunteer and host of this show. AARP is a sponsor of this show, which is one of the longest running shows here on Concord Community TV. Today we're going to talk about aging in place. Many folks want to stay in their own home as they age, and there are many things to consider as we approach this topic, and we wonder whether it's going to be us or it's a family member who's approaching some decisions about where they live and as they get older. So helping us navigate this topic today is Caitlin Cawley. Did I pronounce that right? Cawley?
Cawley, yes.
Cawley, Director of Community Engagement for Home Instead. Thank you for joining us on Senior Speak.
Thank you for having me.
All right. Can you tell us a little bit about your background and the services that Home Instead provides before we get into the topic?
Sure.
Generally?
Sure. So I have been working in senior care for 12 years. So I have worked in assisted living. I have worked in long-term care. I've also been doing home care for 8 years. I've helped in activities, and what I do at Home Instead is I really provide resources to the community, older adults, families, providers who are dealing with older adults to stay safe at home so that they don't end up going to the hospital. Yeah.
Mm-hmm. Okay, great. So many people, when they retire, they hope to stay in their homes and live independently. But what happens when our capabilities start to slip and we maybe need some more help to stay in our homes? It's not a subject that people like to think about.
Mm-hmm.
How do you approach that topic, or how do you think that conversation can get launched?
So I really love when people call me proactively, just knowing, I'm getting older, things are a little slower, it's a little harder for me to get up and down from a chair or something like that, just calling to see what the resources are. Those proactive calls are my favorite because it's really difficult when somebody calls on a Friday afternoon in a crisis. It's important. We have something called the 40-70 rule, and it really essentially says when a child or a loved one is 40-ish, maybe younger, maybe a little older, they start talking to their aging loved one who should be around 70, 80 years old about what their plans are. It's a conversation that should be ongoing. And some of those conversations start with, how can we make your home now safe? What things can we put into place now to make accessibility a little bit easier?
So yeah, and I think we talked about this a little earlier. There are some inexpensive fixes that people can look at to make it easier to stay in their homes. And what are some of those things? We have a list of some of those coming up.
Yeah.
So why don't you go through some of those and why those are things to think about?
Yeah, so sometimes people don't realize that the bathroom and the kitchen are the most dangerous places. That's where falls are most likely to happen. So some of the more inexpensive fixes would be getting a raised toilet seat. You can get one that sits on the toilet, or like a commode thing that goes over the toilet with bars to help you get up a little bit easier. Handheld shower heads, grab bars in the shower, next to the toilet, really anywhere that you need help walking. If you're not using an assistive device like a walker, it would be helpful to have grab bars. Lever doorknobs. So most houses have the ones that you put your hand around and you grip. But if somebody has dexterity issues, arthritis, or something else, it's hard to grasp onto that to open a door. So those lever doors that you just push down make it a lot easier. And then mobile stools. My grandmother, I'm not saying you have to go buy a rubber stool or a mobile stool, but she'll use her computer chair to just get around the house, whether that's to mop the floor or unload the dishwasher, just something on wheels that kind of eliminates the need for walking around. Those are some pretty inexpensive fixes that you can do in your home. Making sure you have adequate lighting, of course, is important. And all of those things are accessible. You can get them at Walmart, you can get them on Amazon, And there are other medical equipment places in New Hampshire, like Refurbished Equipment Marketplace or REQ, all of those types of places that you can buy these things.
Yeah, and there's a diagram that will be put in to the show too that talks about things like lighting, just trying to increase the lighting that's available in your parents or your elderly relative's house. Increase the lighting in the hallways and in other places in general to do that.
Yeah.
And another thing that is a real slip hazard or fall hazard is throw rugs. If you can just go to bare floors or carpeting, that's something really to be on the lookout for. And then taking a more cautious eye about what's outside and maybe strengthening the railing on the staircase outside and just taking a more critical look at those sorts of things.
Absolutely.
I also wanted to mention something that we use with my mother-in-law, who is, she lived independently for quite a while, even though her memory was really going, and she's really technology averse. She stopped using computers a long time ago, but we, through our cell phone company, we got something called a GrandPad, and this is not a paid commercial announcement, but it's called a GrandPad, and it's through Consumer Cellular, and it's a very easy tablet that is designed to be very easy to use. And so it has a opening screen that's just got like 4 buttons on it, and it's just like got email, call, photos, and I forget what the 4th thing is, maybe games or something, very simple games. And the phone allows us to do video calls with her. And all she has to do is hit a button to call us, just as there's no it's got names, it doesn't have numbers for her to remember. It's got names so she can pick who to call, and she just hits a button and it can be a video call. And the video call is really, I find really important for the connection, to know what's going on, because you can't always get it from a voice. Is that what you find?
Yeah, absolutely. And a lot of older adults are sometimes, as you said, technologically averse. But technology doesn't have to be a big scary thing. Something like the GrandPad or even just a Kindle Fire that you can put a few apps on, something like that. Those are so helpful. But also just having an Alexa with setting up reminders, or setting up, Alexa, call Dan, and they'll call your cell phone, or Alexa, set a timer for 8 o'clock to remind me to take my medicine. Technology can be used in so many ways to keep people safe at home. Yeah.
Another thing that I saw somewhere too was appliances that have an automatic shut-off device on them. So that's something to look for in a store also.
Yeah, absolutely. I mean, and we'll talk about it in a minute, but one of the signs that there might be a problem are scorched pots and pans. So having a coffee pot that turns off automatically reduces the risk of a coffee pot staying on, breaking the glass, and then having an accident. Yeah.
So definitely. So yeah, there's I think we have a list of some of the signs that the person is going to need some support, and so that's showing on the screen there, and these are things. So
so like if somebody has household bills that aren't getting paid, that's a big sign that something's going on. And it doesn't have to be something as crucial as bills being unpaid or being unkempt or anything like that. It could be a matter of having a harder time getting up and down from a chair, or forgetting to take your medication. That's a big one with a lot of older adults, medication planning. Other things are scorched pots and pans, of course. Weight loss, weight gain, because that could be a sign that nutrition's not happening. Other signs could be missed appointments or just a general feeling or observance of your loved one having apathy, depression, anxiety. Humans are social creatures, and a lot of older adults, especially if they have something going on medically or cognitively, are really likely to stay in their homes and not want to go out because of what happens if I have an accident, what happens if I forget, what happens if I get lost.
Yeah, and I think it can be kind of a subtle sort of thing where they stop going to something that they went to before, and they kind of brush it off as just being, oh, I just didn't feel like it that day, but then it just becomes every month they're just not going anymore.
Exactly.
Yeah. So, so now we've talked about some of the signs that things would go on that might point us to the need. So let's talk more about things that in-home services that could be provided that your group and others can provide that are not medical. So what are the types of services where you say some more support is needed and modifying the environment hasn't quite done it?
So, there are resources like Home Instead. There are other agencies in the community as well that provide the non-medical home care. So all of our caregivers, care professionals are able to help with tasks like light housekeeping, meal preparation, transportation to and from appointments, errands, or just to get out of the house, med reminders, those types of tasks. But we're also able to help with hands-on care. So if somebody needs help getting up and down from a chair or walking around the house, getting dressed for the day, toileting hygiene, all of our care professionals and the care professionals in home care agencies can help with those supports as well. One of the great pieces of non-medical home care is we collaborate a lot with other community providers. So the goal, if somebody wants to stay at home as long as possible, and statistics show about 92% of people do, sometimes we can help people stay through end of life. So we'll work with hospice agencies, palliative care, and bring that into the home so that they can get their wish to stay at home as long as possible.
Yeah. So now, typically, what kind of arrangement do people make? Is it like once a week or every day, or what are some of the, and how long is somebody, a home care aide, staying in the home typically?
So it really is individualized, which is great, and every agency is a little bit different, but doing this for a while, right now I'm starting to see that more agencies have a 4-hour shift minimum and about 12 hours a week. So 3 times a week for 4 hours or twice a week for 6. A lot of agencies are starting to follow that model. We're starting to notice and see statistically having somebody in there more often or more frequently really reduces the risk of being in the hospital because you have significant eyes on a person. But of course, the financial piece plays into how often somebody comes in as well. How many did you plan for your children or your family members' education when they were growing up, or your retirement? We think about that, but a lot of times people aren't thinking of the financial piece of post-retirement.
And this isn't really covered by insurance. It's not a health insurance thing, and long-term care insurance is also, this isn't really something that would fit into that either, is it?
So it fits in long-term care insurance. It does, yep. So Medicare, Medicaid, I shouldn't say Medicaid because there are agencies that work with Medicaid. Medicare, Medicare Advantage plans, they don't typically pay for private duty home care, but there are long-term care policies that will pay for it. The only thing about long-term care insurance is each policy is written so differently. It's important to talk with an agent or talk with a home care provider about what is covered. So some people may have a 30, 60, or 90-day elimination period, or they might need help with 2 to 3 hands-on tasks in order for it to qualify. Other people have a policy written that it'll be covered if there is a diagnosis and documentation of a cognitive issue.
Oh, okay.
So they might be independent with their hands-on and personal care, but cognitively they need somebody in there for safety and supervision due to a cognitive impairment.
Yeah.
So it's important to look at those plans closely because they are so different. But it will oftentimes cover that. And we work with several of the agencies.
Yeah. A long-term care insurance is a kind of a tricky field.
It is tricky.
It's very expensive, and and the earlier you start getting a policy like that, the more you can likely you are to be able to afford it.
Correct.
And yeah.
Yeah, and we'll sometimes get phone calls of a daughter saying, "Oh, my mom doesn't have a long-term care policy. Maybe I'll check it out." And mom's 96 years old. And I'm like, no.
Even 70 is not a real
I'm
big
like,
deal.
You're much better paying privately. Don't get long-term care insurance at this point.
Yeah, actually, in a previous show we did on mental health among older folks, Dr. Suarez, who was here, he suggested that folks get a cognitive test as a baseline. So even before there's been anything, you're getting older, but before there's maybe even any deficit noticed, to have a cognitive test done, not a complicated one, just a screening that gives a little bit of a baseline, so that when you do notice somebody notices something with their loved one, they can say, "Hey, we've already there's already been a noticed decline that we." And the other thing is, some of these long-term care insurance, they do require the cognitive test when you buy the insurance.
Yeah.
So, and there's also an entry. The cognitive tests are sometimes needed for. You need to have a certain level in order to get into certain kinds of residential setups.
It's never a bad idea to get testing done. If it shows nothing, great. Like you said, it's a great baseline, so you know where you're starting.
Yeah. So, what are some factors that people should consider when they look at an agency? I mean, obviously, home instead is one to be considered, but just in general, is there like bonding, or what kinds of questions can you ask to find out if an agency has good capabilities?
Yeah. So I think the biggest ones are just the hiring process for the care professionals. So a lot of times people will ask us, are your caregivers, or do you do background checks? So you should always see and make sure that somebody's getting their background check done, that they're insured and bonded through the agency. You should make sure that you talk to them about their scheduling policies and dependability, reliability. The basis of building a relationship with a client and a family member is trust. And it's really hard to trust somebody who doesn't show up on time, who doesn't show up when they're scheduled. So how does the agency work with that? What kind of training is provided to the caregivers in order for them to start out in the field? What experience do these people have? So those are questions that you should ask. And then, of course, the questions of staffing, scheduling, minimums, rates, those types of things are important too. But a lot of agencies will offer a care consultation to come in, talk about those things, put together a care plan, and also get a good vibe or not from that general conversation.
Yeah. So it's probably kind of a challenge too, to kind of figure out how to match a caregiver with a particular person, because it's like the personalities have to. This person's coming into your home, and they're part of the role might be companionship, and are they going to get along, and how do you kind of suss that out? Is it something you kind of try to guess at whether somebody is the right temperature for that particular client?
So I can speak for Home Instead in that we're professional matchmakers.
Okay.
So at our care consultation, we talk about what that client's likes are currently, historically, what they might want to do. But we also talk about personality-wise, who do you get along with best? So if a client tells me, you know, I want somebody who has a great sense of humor, a joyful spirit, and is a go-getter, I'm not gonna send somebody who's more serious and reserved to this house because that's just not going to be a good match right off the bat.
Yeah.
So I asked those questions from the very beginning.
Yeah. One other thing that that I wanted to make sure we cover is that what the difference is between, say, your kind of private duty services and VNA, because VNA their aides sometimes will do some of these kinds of things. So what is kind of the difference between what you guys do and what you get if you were using VNA,
So
visiting nurses?
we'll sometimes refer to the visiting nurse. So if we see people having a decline in terms of their functional status, that's a big red flag for us to reach out or have family reach out to the doctor to get a referral for the visiting nurse. The visiting nurse is short term. It's covered by Medicare Advantage. And usually I can't give you a timeline because it depends on the situation, but 2, 3, 4 weeks generally, sometimes up to 6.
Yeah.
But you have a home health aide who comes in for an hour and will do the hands-on care. A PT and an OT, or a physical therapist, occupational therapist, a speech therapist if that's important in the situation.
Yeah, which is sometimes involving like swallowing.
Yep. Cognition.
And cognition issues.
Yeah.
Particularly.
So, they might send those people in 2, maybe 3 times a week, maybe once or twice a week for a speech therapist,
Yeah.
and then a nurse who goes in once a week or every other week. There's a social worker as well. That's not always needed. It's always great to have and ask for, but it's a Medicare benefit, usually following a significant medical event or some medical decline.
Yeah.
So if somebody's gone to the hospital, they've gone to a skilled rehab facility, or they've had a general decline at home, those facilities, those communities will make a referral for the visiting nurse.
Yeah.
Where we kind of dovetail that is working with the PT and the OT to continue on with that support to make sure that the client's not backsliding.
Yeah.
And if we notice a backslide, we recommend reaching out and getting the VNA back in. So we work collaboratively quite often.
Yeah. One thing I wondered about is communication with the family. So maybe the family hired the person how do you communicate with the family about how things are going with the client?
So we establish from the beginning who the point contact is, whether it's the client or the family. We also will get an emergency contact, should there be an emergency. But every single client that we have has a case manager assigned to them. So anytime that there's a change in condition, change in level of functioning, eating, pain level, our caregivers and the caregivers really out in the field should be and are trained to report that to us so that we can call and say, your mom is limping, you might want to keep an eye on it, or your mom's foot is swollen, your dad's foot is swollen. I recently had a family that was out of state, and I saw the client, and his foot was hot and swollen, and I called and I said, right now it's elevated, but you should probably have the nurse come check it out because it could turn into something ugly quick.
Yeah.
So, just communicating everything and anything to prevent any bigger issues.
Oh, for sure. Good. Well, do you have any tips or advice about how to bring up the subject of having somebody come in the home when maybe the client or the individual is a little resistant to the idea? What are some of the ways to bring it up and how to approach that?
Sometimes seeing that there's an issue is a natural way to have the conversation. If there's missed medications or nutrition or depression, is a natural way to have that conversation. Yeah. But sometimes people are like, no, I'm fine, I've got this. It's not necessarily a bad thing to play dirty, and for the loved one to say, this would really help me out. Because as a family caregiver, it's exhausting.
Yeah.
And most parents would do pretty much anything for their kids or their grandkids. So if you're saying, you know, mom, dad, gram, whoever, I could really use some help, that might be a way to get in the door.
Instead of saying you need the help, you're saying,
because
so like an iMessage.
Yeah, and it may not even be that really they need the help, but it gives the family member peace of mind to know somebody's there, checking on their loved one, having conversations so that they could, for example, you know, right now the sandwich generation, we're taking care of aging loved ones, but we also have little kids.
Yeah.
So while we're taking care of our families, somebody is going and helping the older family member.
I think the precipitating event for us to have a private duty person coming in was we're looking at a little bit longer vacation, being away, and it was like, oh, it would be really good to have, you know, that person have an established relationship with somebody who's going to be in the home.
Yeah.
Seeing the person while we're away.
And we've started services with people that way as well. It's just a vacation, and then they kind of just continue on, and then as the need progresses, that happens. I mean, my biggest thing is not to shy away from those hard conversations. The sooner you have them, the easier it is. You know, if you know that your loved one wants to stay at home, what can you do to have that happen? If there's a decline and they end up going to a hospital, just check in with them. Is their goal still to go home? If it is, okay, this is what we need to do for you to get there.
Yeah.
If you don't want to do that, then this is what's going to happen. Yeah. What's more important to you, staying home or not having help?
Yeah, and I've said this to friends and things like that is you really need to be looking a couple steps ahead. Maybe not going there, but having an insight, because once a decline becomes kind of visible, it can be really hard to then scramble and, you know, find a place, a different place to go to. This is a whole different conversation about, which we didn't get to today, of levels of care that are available for, you know, it isn't just like you go home and then you can go to a nursing home. There's a number of gradations between that, which we won't be able to get to today, but that's certainly something to think about is, as you say, being proactive about the discussion.
Those are honestly, they're some of my favorite calls. If I get a call that says, I don't need help right now, but my mom might in, you know, 6 months, 8 months, a year, it's not going anywhere, but you know what, they're reaching out, they have that resource.
Yep, and they know what the landscape is, and we hope that folks take this kind of advice to heart. You say your website has something called the 40-70 rule.
Yep.
Which has got some advice, and that website has some advice about that.
Yeah, so you can either go onto Home Instead and find it, or just type in 4070talk.com, and it brings you right to that website.
Right, brings to that page.
And it has a PDF on there that has an active aging plan that you can print out, and it talks about, and when I say everything, I mean everything. So it's a really great tool. I've used it in my own family to have those conversations.
Yeah, and then AARP, of course, has a ton of resources, and they have something called the AARP Home Guide, which talks a lot. I think that one is mostly about what you can do in order to stay at home, but there's a lot of resources there. So there's a lot of resources out there, and I encourage viewers to check it out. And one last thing, I want to thank you for coming today.
Thank you.
This was a great conversation. I also want to just suggest that if you have any suggestions for Senior Speak in New Hampshire, email them to nh@aarp.org. I'm going to start trying to put that on the end of every show as suggestions out there for future shows. So that about wraps it up. Thanks a lot, Caitlin.
Thank you so much. Thanks for having me.
Bye.